Hello everyone. In today's video, we are going to cover a very important topic both for practical purposes and exam purposes. That is the stabilization of the shoulder complex. So as you saw, there are a lot of structures in the shoulder complex, all of which are not congruent. Whether you take the glenohumeral or the sternoclavicular, acromioclavicular, all these joint surfaces are not properly articulating with each other, because of which they have so many additional structures such as the discs, the labrum, the ligaments, the capsule, all of which are working to keep the shoulder stable, to allow it to be stable while it has so much of movement. Because of this, shoulder will have a lot of static stability components and dynamic stability components to ensure that it doesn't get dislocated or subluxated based on the large amount of movements that we do. So this topic is very commonly asked in exam. It can be also asked as a long answer question. And whenever you see injuries to the shoulder, the main component to be affected is the stability of the shoulder. That's why you'll have to know how the shoulder has its mechanisms to make it stable, both in static ways and in dynamic ways. So static stabilization is caused by structures such as the capsule, the superior glenohumeral ligament and the coracohumeral ligament. So what happens in a resting position is that a strong gravitational pull is pulling the entire arm segment down in a resting position, not during any activity. So here no muscles are acting. So surprisingly, one research showed that even if someone pulls your shoulder down in a static position, the muscles will still not contract to pull it back up. So the main components, passive structures which are giving stability to the shoulder here are the shoulder joint capsule. As you know, it is taut superiorly and lax inferiorly. So the superior taut capsule will pull it up. Second is the superior glenohumeral ligament, which is again placed above the glenoid fossa and the humeral head. So that is the second structure creating this upward pull. And third is the coracohumeral ligament, joining the coracoid process to the humerus. Apart from this, the capsule will have a strong negative interarticular pressure in at rest. So I'm not talking about movement yet. At rest, the capsule, especially the top and the bottom parts, they'll develop a negative intraarticular pressure which will create a very strong vacuum. That's why it's fortunate that the glenohumeral joint has a very strong joint capsule, unlike the acromioclavicular which has a very weak joint capsule. So the strong vacuum produced by this joint will also assist in statically stabilizing this joint. If in case some of these mechanisms are not working, let's say someone has a lax ligament or a loose capsule or a hypermobile shoulder, then the supraspinatus muscle, which comes from the supraspinous fossa and attaches to the humeral head, it will recruit. It's the only muscle which will activate to keep the shoulder in place. So let's say all of this happens, the other rotator cuffs will not work, but the supraspinatus can generate tension to keep the humeral head up. Even though it will not be enough, it will do the job. So to summarize, static stabilization is done by the passive components of the glenohumeral complex, which are the capsule, the superior glenohumeral ligament and the coracohumeral ligament, and a strong vacuum produced by the capsule. If any of these are not working, then the long head of biceps also, which attaches from here and comes over here, long head of biceps, it will not contract, but it will just give a supporting surface. And the supraspinatus muscle will contract to keep the shoulder stable at rest. Now moving on to the dynamic stabilization. If you see the shoulder joint movements overall, we saw that a lot of minor movements are happening at the sternoclavicular, at the acromioclavicular, the scapulothoracic joint, all the rotations happening at the glenohumeral. So all the movements of the shoulder are either, you doing something forward or up, or, combing your hair, brushing your teeth, reaching for something overhead, playing sports. So as you can see, that elevation of the shoulder girdle is one of the prime movements happening at the shoulder joint. Further into the video, we'll also see about shoulder depression, which will happen. But the main focus of dynamic stabilization is for the elevation activities. Now, two muscles are the main movers of shoulder elevation. First is the deltoid, which is situated here, and second is the supraspinatus. Both of these muscles will be responsible for flexion. So, elevation can happen through flexion and through abduction. So the anterior fibers of deltoid will help in flexion of the joint, and the middle fibers and the supraspinatus will help in the abduction. Now, how all of these muscles act and how their forces are counterbalanced, we'll have to go back to a little bit of basics of what we learned in biomechanics. So before we go into dynamic stabilization, you'll have to revise a bit of what we saw in the basics of biomechanics. That is how the muscle fibers can create different action lines for the force. Okay, so for the deltoid, it's a triangular muscle. Okay, it is divided into anterior, posterior and middle segments. So the anterior segment fibers, which are oriented in this way, they will act here. The posterior fibers, which are oriented in this way, they'll act here. But as you know, you cannot have two fibers continuously pulling, otherwise there'll be a lot of confusion as to force will go in one direction and the other direction. So according to the principles of mechanics, there'll be something called as resultant of forces. So if you have one force acting like this and another force acting like this, both of them will have one major resultant which will act in the upward direction. So that is what is happening with the deltoid here. Both of these form a resultant and act through the middle deltoid, which will have a large upward force. So as you can see here, the main function of the deltoid here will be that it will create a very large upward force. Now another concept that you will have to revise from the basics of biomechanics is the resolution of forces. You see that force, the final force is always the resultant. So you'll not know, where the other forces are coming from. For example, forces can always be A plus B is equal to C. If two forces are acting this way, both these forces are added and they will form a resultant. So the concept of resolution of forces is to break down the components of force to understand these individual forces. So to make it simple right now, if there's a force acting this way, there's always going to be a right angle component to it. One force which will act parallel and one force which will act perpendicular, creating a 90 degrees. So you don't have to go very deep into this, but what is relevant for you is, that a joint can have both rotatory motions and translatory motions. So muscles will help achieve that. So as you know from the previous video, you have translations which happen like this and rotations which happen like this. So because a joint can have both rotatory and translatory components, the resolution of forces with muscles can be both in rotatory component and a translatory component. So now I'll show you what that is. So here you've got the humeral head, here you've got the glenoid fossa of the scapula. Okay, and here you've got the deltoid muscle that attaches here. So we are not going to break down the anterior posterior fibers. Okay, so here we'll assume that the deltoid's resultant force is here. If we have to resolve the forces, if we have to break it into rotatory and translatory, deltoid can translate the humerus up. Okay, because of its action line which moves upward, the deltoid which is attached here can move the humerus up. So this is superior translation of the humerus, which will be caused by the translatory component of the deltoid. So we'll call this Fx. Deltoid also causes this rotation, abduction rotation of the humerus. So deltoid will also have a rotatory component to its force. That will be parallel. So this is Fy. So you can name Fy the rotatory component of the deltoid action line and Fx as the translatory component. So as you can see, the translatory component line is much longer than the rotatory component. So by this logic, deltoid is actually having a very large superior elevation force which is happening during elevation. So whether it's flexion or abduction, this motion is happening of the deltoid more than abduction. So you might have learnt in your anatomy that deltoid is a prime mover for abduction and it causes flexion and extension. But according to these forces, what is actually happening here is more than causing rotation. You can see how small that line is. It's not able to cause a lot of rotation. So more than actually causing the rotation, deltoid is causing a very large upward translation force. As you can see, if it's unopposed, this upward translation force will go into the coracoacromial arch, causing an impingement. Now in most of the joints, whenever a compression is applied, it creates stability to the joint. If in practical life examples, if you get a bruise, the first reaction for you is to press it down. Okay, so this pressing down will help you feel a little more stable than leaving it out in the open. Same within the body, whenever there's a compressive force, whether it's on the lumbar vertebra or the knee joint where all the body is compressing it, this compression force, if it's given in the proper amount, it will help the joint be stable rather than a distraction force which is trying to pull things away. Okay, so the upward translatory force will cause translation. The rotatory force on the deltoid will try to, because it's a horizontal force, okay, it's not a vertical force, the rotatory component is horizontal, it will cause a compressive effect. But the problem here is the humeral head and the glenoid fossa are not aligned vertically. The humeral head is slightly abducted. So instead of causing compression, so compression should ideally happen here. But instead of causing compression, the deltoid action line, which will be here, will go like this. So it's rather creating a shear force. Shear is when two forces are acting horizontally like this. So that's why even though the deltoid will try to stabilize the joint, more than compressing, it's causing a shear. So overall here you can see that the deltoid is not an effective muscle to cause a elevation on its own. And if it's acting without any other muscle trying to support it or counteract it, it will cause only a translation which will go right up to the coracoacromial arch. And therefore it needs the rotator cuff muscles to help create the stability against this excessive elevation that is happening. So what the rotator cuff muscles will do, they will offset the forces. Otherwise, if they are not offsetting the forces, deltoid upward translation to the coracoacromial arch will happen before even abduction has occurred. And that is definitely not an ideal situation. Imagine causing impingement of the structures when the arm is not even abducted this much. So that's why you've got the main rotatory muscles coming into picture. There are four rotatory cuff muscles. First is the supraspinatus, second is the infraspinatus, third is the teres minor, not major, teres minor, and the subscapularis. All of these will also resolve into their action lines and counteract the force of the deltoid. Now we'll see how that happens. So of these four rotator cuff muscles, the supraspinatus will cause abduction. Okay, we'll see how that happens. Infraspinatus and the teres minor muscle will cause external rotation, both of them, and subscapularis, which will cause internal rotation. So based on their placement, we'll see how the action lines are. For reference, I'm still going to draw the deltoid action line. So you've got the humeral head here, the glenoid fossa, the rest of the scapula. We've got the deltoid here, and as we saw before, it has a large translatory force, upward translatory, and a small rotatory. So the upward translatory is Fx, the rotatory is Fy. Okay, I'll just mark it in brackets. Now comes the supraspinatus muscle. So again you have the glenoid fossa, the spine of the scapula, the rest of the scapula, and the supraspinal fossa. And then you have the humeral head. So supraspinatus muscle will start from the supraspinous fossa and attach below the coracoacromial arch to the glenoid, the humeral head. So now you can see that the orientation of the muscle fibers of the supraspinatus are horizontally, not exactly horizontally but obliquely horizontally. So unlike the deltoid, they are not going to act vertically. So again, the fibers, they will resolve into two components, the rotatory component and a translatory component. So supraspinatus, because it's an elevator of the arm, it will also cause an upward translation. So that's how it's going to cause an upward translatory force. But unlike the deltoid, the fibers are oriented horizontally. Therefore, it's going to have a rotatory action horizontally. Okay, so because of the horizontal placement of the fibers, this is the Fx component, which is a rotatory component, and this is the, so supraspinatus will have a very small translatory component. So this will be Fy, which is translatory. So that means that the supraspinatus, which is over here and comes over here and attaches to the deltoid, because of its action line being horizontal, it is much more capable than the deltoid to cause an abduction. Okay, because it has a very large rotatory component, and because it has a very small upward rotatory component, upward translatory component, it will not be able to cause as much elevation as the deltoid. So whatever compressive effects were not being got by the deltoid because of the small rotatory component of the deltoid, the compression to this joint will be mainly given by the supraspinatus. Even though it's an elevator, along with elevation, the horizontal action line of the supraspinatus is going to cause compression. So, one part of dynamic stability is given by the compressive effect of the supraspinatus muscle. Now, we have seen that both the deltoid and the supraspinatus will cause elevation. Deltoid will cause more translation than abduction rotation, whereas supraspinatus will cause more rotation than a translation. But this still doesn't solve the problem that everything is going in the upward direction. So now, to cause the offsetting downward pull, you have the infraspinatus, teres minor and the subscapularis muscles. Subscapularis will be here on the inner part of the scapula. Infraspinatus will be here and teres minor will be just below the infraspinatus. So all of their orientation will be towards this side. Okay, so most of their action lines will be the same because infraspinatus and subscapularis are just opposite muscles, front and back. Both of them, their muscle fibers will move in this way, oblique horizontal way. We can say that these three muscles will have a similar action line. So you need not draw all the three muscles and their force components separately. Okay, again here you have the glenoid fossa, you have the scapula, inferior angle, then the spine, supraspinous fossa. Then here you've got the humeral head. Now here you have the infraspinatus, okay, which is covering the entire infraspinous fossa. Exactly behind you have the subscapularis, and you can see that the action lines are more or less horizontal. So this is going to cause a resultant force which is like this. You can resolve it into rotatory component and the translatory component. So again we will name the rotatory component Fx, translatory component as Fy. Because of the large surface area of both the infraspinatus and subscapularis, their rotatory component and the translatory component will be somewhat equal. So they can effectively cause rotation and they can effectively also cause a downward translation. As you can see here, the action lines here are completely opposite. So unlike the supraspinatus and the deltoid, which is causing an upward elevation, three muscles of the rotator cuff will work together to create an action line which will go down. And obviously it is assisted by gravity as well. So whenever you are having any flexion elevation activities and abduction elevation activities, like if the abduction is here, as we saw in the basics of biomechanics, gravity will act from here because this is the heavier end of the shoulder. So you already have gravity acting here, and from the muscular placements you've got the action lines acting like this. So to summarize all of this, the dynamic stabilization is needed during elevation activities of the shoulder. The elevation is primarily caused by the supraspinatus and the deltoid because of their action lines. Deltoid is creating a translatory force, supraspinatus is creating a compressive force or rotatory force. Both of these muscles are creating a large elevation, which is again not an easy task because the humerus is a very large bone and it's also very heavy to lift against gravity. That's why you also need such a large translatory force. But if it is unchecked, the humeral head will go into the coracoacromial arch, pinching everything which is there. The rotator cuff tendons, the supraspinatus tendon, the long head of biceps, all of that will get pinched before even elevation will occur. So during elevation, to offset the translatory force, you've got the other three rotator cuff muscles to create a downward pull because of their action line. So the infraspinatus, the teres minor and the subscapularis, all they are oriented in the same direction. So three of them will create a downward pull. And according to the concept of resultant forces, both these forces will be in the same plane. So all these three muscles forces will be added. So to offset the upward effect of two muscles, you've got three muscles whose resultant is downwards. So that is the overall concept of dynamic stabilization of the scapula. If it's asked in the exam question, you have to write about what dynamic stabilization is, why it's needed in the shoulder joint because of its lack of static stabilizers. Or it's not lack of static stabilizers, but even after having so many static stabilizers, it is still not enough to stabilize the shoulder. Then you draw the three muscles like I showed you here, and you draw their action lines while naming them, which is a translatory component, which is a rotatory component, and also show that the two opposite action lines will offset each other to create a smooth elevation activity.